Okay, I've started recording.
Sounds good. It's 3 o'clock, and welcome everybody to the Build Your Bones series. And I say series meaning two parts. Today, we're delighted to have a very special guest, but I'm going to let Dr. Dahl introduce her in just a moment. But we're excited that you're here, and hopefully, all of you were folks that attended our session in NEAFCS last year. We're delighted to provide you with this update today. And then we'll be introducing the Build Your Bones curriculum and providing you access to it on March 5th at 3 o'clock. And that's going to be Eastern time. So March 5th, 3 o'clock, save the date. And we'll send out some reminders for that as well. So we're excited you're here. And without further ado, I'm going to pass it over to Dr. Dahl.
Thank you, Wendy. Could I have the next slide, please?
It's not behaving. There we go.
Okay, thank you. All right, it's my pleasure today to introduce Dr. Susan Whiting. She's a distinguished professor emerita of nutrition at the University of Saskatchewan, where she taught for 31 years in the nutrition and dietetics program. Previously, she taught at Mount St. Vincent University in Halifax, Canada. Her research spans dietary influences on bone health of children, adults, and older adults, effectiveness and safety of calcium and vitamin D supplements, and food security at local, institutional, and international levels. She has been a member of the Scientific Advisory Board of Osteoporosis Canada for 23 years and is a fellow of the Canadian Academy of Health Sciences and the Canadian Nutrition Society. She has served on international advisory boards related to bone health, dietary supplements, vitamin D, and the dietary reference intakes. Welcome.
Well, thank you, Wendy, for that introduction. And I have to say, I'm very pleased to be joining you from Saskatoon, Canada. And a bit of a daunting task to provide an update to osteoporosis. The Build Your Bones curriculum is very up to date itself. But fortunately, I was able to find, I think, a few resources and just some ideas that might be useful as you go forward here. As is customary, I'm just drawing your attention to whether I have a conflict of interest in presenting this information. I have no financial interest in anything to do with bone health except my own. I'm currently working with a physical trainer, so I'm the one dispensing the finances there. I serve as a consultant to the Public Health Agency of Canada. They're looking at whether recommendations or more recommendations for vitamin D supplementation are in the cards. And this is just I'm serving as an unpaid consultant on this. And as Wendy mentioned, I have been connected to Osteoporosis Canada for quite a while now. Guidelines were, we had guidelines in 2002 and also 2011, and now I'm going to be sharing new guidelines with you in this talk. I also want to acknowledge that I am presenting some slides or modifications of slides that I derived from a talk that Osteoporosis Canada had just in December of this year. So I've indicated those slides with OC for Osteoporosis Canada in 2023. Some problem with my old computer here at home. So a definition of osteoporosis, it's been around for a while, certainly 30 years of in the public eye. That's when a lot of societies were created, such as Osteoporosis Canada. And pictures here were published in 1986, and I still see them used. So those early years were very important in describing low bone mass and microarchitectural deterioration. So it's not merely low bone mass, although we often say that because that's what we can measure. But there's also things going on inside the bone that will lead to fragility and susceptibility to fracture. The major fracture sites are usually described as the wrist, the spine, and the hip, but other bones have been added as they're becoming more familiar. The reason that their wrist is there is because if you fall and you still have some balance left, you tend to fall on your wrist. And with low bone mass and poor bone structure, you'll break your wrist, but that might be the worst that happens at that point. If you don't have good balance and you fall, you're possibly going to break your hip. And that's where things really begin to fall apart in terms of a person's social, physical quality of life. And the spine, we're going to spend more time on the spine as well because it affects body composition and has devastating effects on a person's ability to move, as well as produces a lot of pain. So in thinking about what to present today and realizing that we just have this hour, I'm going to describe recently published osteoporosis guidelines, those from the United States and those from Canada, which came out quite almost at the same time. The reason for doing this is these guidelines are created by experts in the field in that country, and they really represent evidence-based as well as practice-based information that is as up-to-date as can be. Also, they are reviewed because they get published in journals and they get reviewed by experts who then have a chance to really make sure that everything that's being presented is as correct as it can be. The second objective will be to look specifically at the nutrition recommendations because that is my area. And just some information on how you can use the recommendations to help people make food and supplement choices. And finally, some information on what is on the horizon, what nutrients aren't in the guidelines or they're mentioned but not really indicating that there's quite enough evidence yet, and then to talk about bone healthy food patterns. So just to start, the consensus statement from Bone Health and Osteoporosis Foundation, the BHOF. Now, this was formerly called the NOF, National Osteoporosis Foundation, and they recently changed their name because they wanted to be more than osteoporosis. So they wanted to reach into everybody's life and say bone health from conception to old age is important. And let's not only focus on the disease osteoporosis. However, their guidelines, and they really are, although they call it a consensus statement, these are restricted to those 50 and over and or women undergoing menopause. And so just I'm going to focus primarily on that group as well and bring forward what these guidelines are telling us. Now, in addition to those 2022 from the BHOF, Osteoporosis Canada issued its guidelines in 2023. And I'm not going to compare and contrast these guidelines, but there's a reason that I'm bringing the Canadian ones in, and I'll show you in a minute. But it means, as I said, we'll be focusing more on 50 and over, because both those guidelines specifically talk about that, focusing primarily on primary osteoporosis, acknowledging that there's a lot of reasons why people lose bone and lose bone mass from other diseases and from medications and just many out there. Now, even though we're focusing on detection, assessment, and management in osteoporosis of older adults, it does cover aspects of prevention as well as treatment. So this is a diagram that gets published in many reviews on bone health because it shows that there is during our lifespan or life cycle at different points, we can focus on different types of concerns for bone health. And certainly with childhood and adolescence, There's a lot of information now on how bone is accrued in those ages, how important exercise and nutrition are to that. And I have to say with some regret that it would be nice to be able to cover that area, because in Saskatchewan, we had an ongoing study of what happened during childhood, adolescence, and into young adulthood that I'm very proud to have been part of. However, we're going to look more at the what happens as adults who, when they go through 20 to 40 or so, they're just maintaining their skeleton, hopefully not doing anything that will compromise it. But with menopause and with more advanced age, we do see a decline, as shown here. Now, there are many ways to express the differences between what males and females undergo. But I think the important thing, even if osteoporosis is less common in men, it is present and it is there, and it can be a real public health concern. So this is the title page of the Bone Health Osteoporosis Foundation Consensus Statement. It's written by 7 experts in the field with others who contributed. That's one of the reasons it's called a consensus statement, because they didn't go through a full systematic review of all the literature, but it's very thorough, 51 pages, and this is that journal page type, which is small and dense. 14 tables, 7 figures, and 369 references. So there's a lot of information in this document that I'm going to bring some of it out and show you. And as I mentioned, now just a year later, but probably working on it all through those early 20s, the Canadian practice guidelines were released actually in October of 2023. More authors involved because they did go through more of a systematic review of the literature. But one of the interesting things that they wanted to let people know is, for many of the groups or many of the topics that they were investigating, they always had a patient representative on different panels. And so sometimes the language and the recommendations that the Canadian guidelines bring forward has a patient perspective. So when it comes to looking at management with medications, with the different drugs, what do they cost? What are the side effects? Those sorts of issues were brought forward by the patients themselves. So that was, I think, quite innovative. But the main reason I'm even describing the Canadian guidelines to you is this, a flow chart. It's amazing. It's a 1-page in the journal article. It's like an infographic, although there's a lot more words than most infographics would allow. But just their use of color too is saying that somewhere along the line of assessing risk factors, you're going to find that people have low, medium, or high risk. And when you identify people in those categories, what are you going to do with them in terms of management? And more at the top, all the risk factors and other ways in which osteoporosis or bone health can be assessed are mentioned. And there's pretty good agreement between what the Canadians say and what the Americans say in these two publications. But what we have here is just all in 1 page. So it's quite a feat. And they started with this in the 2011 guidelines that I was involved in. And I think because these guidelines tend to be aimed at primary care physicians or nurse practitioners and others, it's very much appreciated that it's been distilled down to this flow chart. So if we start at the top, it says that we're dealing with postmenopausal women and males over 50. Of course, we know that women can have early menopause, or they can have reproductive problems much earlier than age 50. And so that's why the age is really more related to men. And of course, there's a lot of clinical judgment that goes into every one of these cutoff. So we don't want to take it literally that a man who's 49 isn't going to be doesn't figure into what's here. But what it starts at the top is that everybody, for the sake of their bone health, has these three recommendations. First one is to recommend balance and muscle strength exercises greater than twice, at least twice or greater than twice weekly. And that's really the first time that such a prescriptive amount of exercise has been given. Usually it's stay active or keep active, but you'll find in both sets of guidelines, and I can't go into this myself, but it's written quite well in the Build Your Bones curriculum about the nature of those exercises and what you're really trying to accomplish. Now, another aspect of the Canadian guidelines is because they did a systematic review, they present their recommendations in grade format. And so those with high evidence or strong evidence, the sentence starts with recommend. And those with less than strong, somewhat weak evidence, they start with the word suggest. So the exercise has recommend because the evidence is really very strong. And one reason it's very strong is there's another group in the world very interested in bone health, and that's astronauts. So we have NASA and the European Space Agency working to prevent bone loss and muscle loss in astronauts on long journeys. And so a lot of the breakthroughs in this area were actually done through those space agencies. Now, in terms of nutrition, we've always had a calcium and vitamin D recommendation, but what is new in both guidelines, American and the Canadian, is a focus on protein. So protein has been elevated, and now we have three critical nutrients: calcium, protein, and vitamin D. And it's suggested that the way to get calcium and protein is to eat foods, get them through foods, make good food choices. To get vitamin D, though, it really is difficult to find ways to meet vitamin D through foods that are easily accomplished. And we'll get back to that in a minute with some other slides. In Canada, though, our recommendation is fairly low at 400 IUs, and it's kind of a minimum amount. But what they're saying that is, I think, an important one is they're saying everybody needs this. So we maybe have to stop assuming that there's ways to get vitamin D from food and say it's very likely that you can't meet it all from food and that a supplement is going to be required. At least in Canada, where we have slightly longer winters, our vitamin D levels drop a lot through November to April. And our food supply is improving, and I'll tell you a bit about that. But from calculations, it's not possible to meet the RDA without this supplement. Now, other aspects of these sort of prevention-related recommendations are, as I said to you, if you improve the diet, it's balanced, it's healthy, then you'll likely meet calcium and protein. However, in some cases, a more individualized approach may be needed. And they're saying to physicians and other primary healthcare providers, find a dietitian to do this. They're trained and they have the ability, and this is where they need to be brought in. Next is assessing risk factors, and the risk factors haven't changed a lot over the years, but one that has really become very prominent is that the idea that if you have an adult fracture, and that's what the BHOF calls it, they just say an adult fracture, it's likely that you have at least early, if not full-blown osteoporosis, because you really shouldn't be fracturing in low trauma situations. Now, in Canadian guidelines, they're a little more, they give a little more detail, and they say these fractures would occur after the age of 40, Again, they're low trauma. Fractures of the hands, the feet, and the face are not considered to be osteoporotic fractures. And some of the slogans that have been tossed around are things like make that fracture your last, meaning if you have a fracture as an adult, go and see what you can do to prevent further bone loss or to build your bones back so you don't fracture again. The other important risk factors that have been around for a long time include use of glucocorticoids, prednisone, and both Canada and the United States have a similar dose, which for Canada has been lowered. And it's usually 3 months or more that you're on this. Having falls, especially in the last year, means that you could have a balance problem. It could be muscular. You need to be assessed because as you fall, your risk for fracturing increases. And then there is a parent history. There's a lot of reasons for secondary osteoporosis that are interesting, but things like malabsorption or having another disease that impacts the main players such as calcium and vitamin D. Smoking, alcohol overuse are still important risk factors. And then a low body mass index. Now, the BHOF just calls it low body weight. The Canadians say less than 20. And the reason this might be interesting to you is, of course, when we talk about normal body weight and then overweight and underweight, usually the range is 18.5 to 25 kilograms per meter squared. So this is saying that even between 18.5 and 20, that is a low body weight that puts someone at risk for osteoporosis. Another reason for bringing in the Canadian guidelines is this picture. Now, both Canadians and Americans specify that a height loss, a historical height loss from when you had last measured your height, perhaps when you were a young adult, what your highest height was, or recent height loss. If you can have these measured fairly accurately, this is an indicator of vertebral fracturing. And you can see that here's a skeleton that would be unaffected by vertebral fractures, and a 3 centimeter or a 1.5 inch height loss is indicative that vertebral fracture is taking place. And then as it gets worse, you can see that the skeleton is now, the vertebrae has been affected. There's a lot of crush fracturing going on. And so this is a way in which the interest and the concern that you might have, that you can invoke in people, let's say at a health fair, to get their skeleton or their bone health examined, is through talking about this height loss. A second measurement that's not included in the American guidelines, but the Canadians have adopted it, is can you stand against a wall with your shoulders and your hip and your heel and look straight ahead? And what is the gap between your head and the wall? And if this gap is here, it's 4 centimeters or just under 2 inches, that's okay. Things look good. But as it gets wider, again, it's indicative of the change in posture, which is being forced on the person. It's nothing that they have control over, because their vertebrae is crushing and due to fracturing, and they're just leaning over. So that is something that could be done more with trained physiotherapists, I think, than in a health fair. But it does kind of give, what does it look like? What does this look like? And then the third one is called finger breadth, and it's really saying as the skeleton bends, the distance between the bottom of the rib cage and the top of your hip gets narrower and narrower until there really is no more distance. The finger breadth here is 0. So you want a healthy 3 or more finger breadths, then 2, and then with 0, that person has undiagnosed vertebral fractures. In the next stage is to screen and assess osteoporosis risk, usually using DEXA and getting a bone mineral density measurements. Also, both countries use FRAX, which is an algorithm that uses, sometimes you don't even need a BMD measurement, but it uses the most common risk factors and puts together a 10-year risk of fracturing. And those with the highest risk can be differentiated from the lowest risk. And then there's people in the middle of those two extremes. The nice thing about looking at this in this diagram is that it pertains to pharmacotherapy. So someone who's low risk, no matter what their age, but if they have low risk, then pharmacotherapy is not recommended. There's really no benefit to it, to the person, to the cost, to the possible side effects. Someone with high risk, using the grade system, it's recommended that they have pharmacotherapy because you'll have the largest benefit. And in the intermediate risk, you can see using the grade terminology, it's suggest. So it's a conversation, it's thinking about what could be started, maybe have some discussions about the nature of that pharmacotherapy. And that sort of allows the most important conversations maybe to be made to people with this intermediate risk. And then what follows after a period of time is a reassessment. So even the person at low risk at some point needs to be reassessed because something could have happened that is now putting them into a higher category. And any fracture that it's going to occur after assessment here is going to play into the management decisions. Well, what are those pharmacotherapy options? And I like this table because it divides, and most people agree with this, that the current options for bone health osteoporosis medications are either anti-resorptive or anabolic. So they either slow down the normal resorption that's taking place on bone, and that's mostly to inhibit osteoclastic activity, or they are anabolic, that is, they're involved in bone formation, and they stimulate new bone formation primarily through the other cells, the osteoblasts. Now, I have a picture of that in the next slide, but just to spend a minute here looking at these medications, all of these are available in both Canada and the US. Our Health Canada sometimes is a bit slow to approve new drugs. And has concerns about one or two of the drugs that the BHOF lists, but these ones are the major ones anyway. So it's shared between both countries. The bisphosphonates are the ones that have been around for several decades now, and how they differ is that the early ones, alendrolate, which was initially brought out as Fosamax, is a daily or weekly preparation. Risedronate is monthly, weekly or monthly, and zoledronic acid is injected. It's injected IV. And so these give patients a choice because daily can be difficult for people. And the bisphosphonates work by, they're really phosphate molecules that are poorly absorbed, but once they are absorbed, they go straight to the bone, they become embedded in bone mineral, and they are a part of bone mineral, and they make it harder for osteoclasts to break down. So because they're poorly absorbed, it means that a person has to wake up in the morning on an empty stomach, take the medication, stay seated, not go back to bed, not lie down, so that that will maximize the absorption of the bisphosphonates. So you could see why people didn't want to do that every day. So weekly versions came out, and then monthly versions. And then finally with the once yearly, that means that once a year you get an injection. Now, with that injection comes higher cost, and also there's some side effects that are unpleasant for a few days. So those are the sorts of choices and discussions that would take place. The most potent anti-resorptive medication is denosumab. And denosumab inhibits the cytokine, and I'll show you on the next slide where that's taking place. But it really cuts down on osteoclast activity. It's the most potent. It interacts with the cytokine. It's an antibody, and that's what the MAB at the end of its name means, monoclonal antibody. It means then if it's an antibody, it can't be ingested orally, it has to be subcutaneous, and it has to be every day. And it has to be, you have to be committed to taking it. It's the most potent, but when you stop taking it, it has some pretty nasty effects. Raloxifene isn't as commonly administered, but it's sort of there if these other ones aren't working for a person. And then I'll just mention that hormone therapy using estrogen and estrogen progesterone has made a return. There was some of the Women's Health Initiative that came along a decade or two ago and said that there was cancer risk with using estrogen. And that kind of cut back on people willing or wanting to take it, physicians wanting to recommend it. A re-examination of that study and other subsequent studies have shown that the Women's Health Initiative had a design flaw. They gave hormone therapy to women over 60, where if you're seeking menopausal relief and using estrogen for even up to 10 years after menopause, you are not 60, you're probably late 40s to late 50s. And the risk is really quite minimal. So it's certainly making a comeback, and it's considered an important choice. Those are the anti-resorptives. The anabolics, there's two different kinds. Teriparatide is a parathyroid hormone analog. Parathyroid hormone in the body actually causes bone resorption. And it's just part of the cycle of getting calcium from bone and maintaining blood levels. However, it was quite difficult for people to understand for a long time that when they injected parathyroid hormone, it had a different action, and it actually promoted bone formation. It took a while to realize that these were two different actions due to administering the same hormone differently. So the body reacted to it differently. And so teriparatide has become really the hallmark of a bone formation drug. But because it itself is a peptide hormone, it has to be injected and injected daily. Romosumab, as the ending indicates, is another monoclonal antibody, and it is an antibody to a different cytokine in bone modeling turnover, and I'll show you that in this diagram. So here's bone remodeling. I went looking on just on Google because it's a wonderful source. And people are always willing to put nice diagrams in their journal articles these days. Unfortunately, I couldn't find one that was actually a cycle, but this one I think is pretty good. Bone remodeling is what you need to keep your bones, you're repairing them every day from small little fractures. And you're also maintaining blood levels of calcium by breaking down small portions of your bone and then building it up again. It's important. You can't stop bone resorption. You would not want that to happen. And you also can't overmake bone because there are conditions of diseases out there, people who do, very rare conditions, and they don't have a happy time and their bone is not normal. So we want bone remodeling to take place, but we want to be able to cut back on the resorption when it seems to be accelerated for various reasons. And we want to promote bone formation, and we want to maintain the skeleton. So the anti-resorptive medications on the previous slide the bisphosphonates were working by incorporating into the bone that these little osteoclasts, see how they are sort of have these edges, that maximizes their surface area. So they're able to break down more bone in a shorter period of time. And denosumab prevents the conversion or slows it down. It doesn't completely get rid of it, but it just makes the conversion of pre-osteoclasts to active osteoclasts a little less effective. So there's fewer osteoclasts, but it doesn't shut it down completely. When osteoclasts act on bone, they create these cavities, and then osteoblasts come along and make new bone and fill up those cavities. Now, there is a cytokine that prevents the conversion of pre-osteoblasts to osteoblasts. It's called sclerotin or something like that. And this cytokine is released by cells inside the bone just to control. You don't want to disturb the normal homeostasis of this bone remodeling. The newest drug, romosozumab, actually prevents that inhibition so that more osteoclasts are made. So we are able, through management, through this pharmacotherapy, to modulate bone resorption or to promote bone formation using these drugs. Most start with an anti-resorptive, and most start actually with a bisphosphonate, but there may be many reasons why. And there are many scenarios of what happens when someone is intolerant or it doesn't work and things like that. That's the reason why you need to have a lot of different choices when you're managing osteoporosis through these medications. Now, they're not without risks. I mentioned some side effects and just some peculiarities about having to inject or needing to, sit quietly for 30 minutes in the morning once you've taken your bisphosphonate. But over the decades that bisphosphonates have been used, a number of very rare conditions, less than 100 per 100,000 person years. So it took time for some of these to show up, but the two that seemed to be occurring were ONJ, osteonecrosis of the jaw, and AFF, atypical femoral fracture. And when these were being documented and more we're seeing, even though it is rare, it's coming up because of the use of bisphosphonates. Researchers and physicians started to think, well, maybe bisphosphonates work so well, they get incorporated into the bone, that we should consider a drug holiday. And so that is now part of the guidelines. Someone will take a bisphosphonate for, say, 3 or 6 years. Their bones have not worsened and in many cases have actually improved. Then you don't need to keep taking it. And so you stop taking it for a number of years, and this is referred to as the drug holiday. So that has been sort of an innovation responding to these rare but concerning events. With denosumab, as I mentioned, it's the most potent anti-resorptive, which is great. But when they discovered that people stopped using them, there was a rebound and they actually fractured more. So there were vertebral fractures occurring once patients stopped the denosumab. And so the plan now that is in the guidelines, in both country guidelines, is to, first of all, in the Canadian one especially, they say, don't give denosumab to someone who might not take it. So make sure there's a long-term commitment. And then secondly, when denosumab is stopped, then you need to continue with an anti-resorptive. So this has come from what's happened in the medical, in the literature, and by sharing the side effects that had been occurring. So I copied this out of the New York Times story that appeared a few years ago, because I just thought it highlighted that if your patients have concerns about bone drugs, then they're not going to take them. So the conversation and the management has to continue. It's certainly important to provide the proper choices for these medications and make them suitable to the person who is taking them. So I'm going to switch now to nutrition and look at the evidence for, or the recommendations that are now in the guidelines. So we have calcium, protein, and vitamin D, where protein is now being highlighted, and calcium and vitamin D remain as important. For calcium, there's sort of a food first. Try to obtain your calcium from food sources. Although it is mostly discounted now, there was a concern that calcium somehow, from supplement use, somehow interfered with it came in the body much too quickly and caused calcification and maybe put someone at risk of heart disease. So most of the evidence for that has been re-examined, and there's a lot of systematic reviews out there saying that there really isn't huge evidence. But it seems that when you take calcium from food, its absorption is prolonged rather than all this calcium coming into the body in a fairly high dose supplement and sort of flooding the system. So that's one of the reasons why looking at food. A second reason is that most of the calcium sources are either naturally healthy, or the fortified ones tend to be foods that are healthy, like orange juice. Or in the case of plant-based beverages, you're providing an option for someone who, for whatever reason, has chosen not to use a dairy product. Then now you have a plant-based equivalent in terms of calcium. The values for calcium are the 2011 RDAs. And so that means for women over 50, it's 1,200. It doesn't change. But for men, it's for 50 to 70, it's 1,000. And then for men over 70, it's 1,200. The 1,200 is really recognizing that you're dealing with people who are at high risk for losing bone. And so maximizing calcium intake during that age might be a good thing. There isn't really a study that says that 1,200 specifically is needed, but it points out that emphasizing and maximizing calcium intake might be helpful. Now, we often, as I said, look at dairy as a source of calcium, but with fortified food choices, people can pick orange juice and tofu is kind of like a fortified food because calcium sulfate is used to make tofu. Now, Canadians have a love affair with canned salmon. So I should really justify why this fish is appearing here. We like canned salmon. And when you eat canned salmon, bones are there, they're crushable, and you can mix them in to a casserole or in a sandwich or whatever, and that's a really good source of calcium. Similarly with sardines, so if you have the whole fish, that's okay. Fish alone, not so high in calcium. So that's just to explain why this fish figure is shown here. But we know that other foods can contain calcium, and eating, maximizing greens, things like kale and broccoli is a good way to get calcium. And as we now promote beans and peas and lentils, these foods also can contain calcium. And so you don't have to only eat foods high in calcium to get calcium. You can eat a lot of food servings through the day that will provide smaller amounts of calcium, but still obviously very important. Now, it might be useful for people to determine how much calcium they are consuming from foods. And so in Canada, we have a calcium calculator that's on our Osteoporosis Canada website. The BHOF has a small calcium calculator, only comprised really of dairy foods, and says if you eat these foods plus let's say there's 250 milligrams from other sources, you'll be fine. But I think we need to allow people who do eat a lot of healthy foods to discover what their actual calcium is. And so what you can do is either through the Bone Health and Osteoporosis Foundation site, or you can go directly to the International Osteoporosis Foundation website. There is a calcium calculator for almost every country. So you select your country and the language. Now, by selecting the country, it would be really nice if they selected calcium fortified products unique to that country. But I actually have a feeling that all you're doing is selecting what standard your intake is going to be judged against, and that would be the current RDAs that we have from the Institute of Medicine. You select whether you're male or female, because if you just saw men 50 to 70 have a different RDA than women. And then the age, and the RDAs for calcium vary by age group. And then in some countries, people with osteoporosis might have a higher calcium recommendation, and so they ask this question. But it is a way, at least, to help people determine if they're getting enough calcium, and also to quantify it. Because to quantify it means that you're either going to make an effort to get that extra calcium, or you may end up taking a supplement to fill that gap. Protein, the BHOF guidelines say adequate protein, which we would then translate as the RDA. The Osteoporosis Canada guideline says, well, let's tell you what the RDA is. It's 0.8 grams per kilogram. But the the International Osteoporosis Foundation says 1 to 1.2. Now, you have to realize that right now, the RDA for protein is undergoing possible revision. That is, NISM, which is now taken over what the Institute of Medicine used to do, to develop standard dietary recommendations for the macronutrients, is working through all the macronutrients 1 year at a time. They finished energy and they're now on to protein, and who knows what the recommendation might be. But it wouldn't hurt to think of one. First of all, the math of multiplying people's weights in a number that you might not be familiar with. We use kilograms a little more often than you, but and people might be more familiar with pounds. If you thought of it as 1 gram per kilogram and kind of went that route, that would help with people's math literacy. I think the most important message about the protein in these osteoporosis guidelines is that protein should be at every meal. So if you did calculate a recommendation of 60 grams of protein, having a large meal of protein at dinner time is not a good idea. It actually doesn't work as well as, let's say that 60 grams of protein isn't going to improve protein balance or nitrogen balance as well as 20, 20, 20. That is dividing that into almost equal amounts. So we need to be working towards not just the amount of protein that people need, but also when they consume it. There seems to be a lot of debate about whether it should be animal or plant, but there's advantages for both in terms of the other nutrients and other bioactives that they bring with them. So animal sources tend to have calcium and vitamin D when you ingest dairy products or fatty fish with those all-important crushed bones. Or plant sources provide fiber, omega fatty acids, and other bioactives such as polyphenols. So I think the bottom line is a mixture. It doesn't matter. It's not going to make a huge difference, plant or animal, but having a mixture means that you're getting more variety and more nutrients in your food. And of course, your plate is useful because you actually have 4 groups that could contain good protein sources: whole grains, all the foods that are in your protein group, and the peas, lentils, and beans are sometimes put in the vegetable group, depending on really if you've already met your protein requirement. Eating extra plant-based protein become a source of fiber and other important things that vegetables give you. So you certainly use all those food groups to your advantage in promoting protein. We know that insufficient protein can lead to sarcopenia, poor muscle loss, and that decreases mobility. The low mobility means that that person isn't exercising strain, mechanical strain, and so that's a reason that bone turnover is actually favoring resorption over formation. There's an increased risk of falling because of the low muscle mass and poor balance, and that can lead to an increased risk of fractures. So protein has certainly become important in these guidelines. So as we think of the third critical nutrient, vitamin D, we have to realize that there's not a lot of foods that naturally contain vitamin D. And of course, we know that through sun exposure, we can make vitamin D. But the Canadian guidelines are quite adamant to say we cannot use sunlight as a source of vitamin D. The reason being that there are many reasons why people don't get adequate sunlight, and in addition to just the differences between winter and summer, clothing, sunscreen use, just not even being outside, working inside, staying inside, lots of reasons that we shouldn't assume that people can have enough vitamin D. And there's enough studies around the world in equatorial areas, cities, countries that are on the equator that show that vitamin D deficiency is very possible. Natural sources, though, are few and tend to be primarily animal-based. So fatty fish and eggs are natural sources. So to combat that, both Canada and the US have fortified milk for many, many decades. And then with plant-based beverages, they've come along and mimicked that same fortification. Sometimes they'll use vitamin D2 instead of the natural vitamin D3, but for most purposes, they're very similar. And fortification is permitted in yogurt and cheeses, but not always on a mandatory level. And so expensive foods are not necessarily going to be accessed by those who have food insecurity. I also put mushrooms here. Irradiated mushrooms are also a source of vitamin D, but I'm not sure if they've reached that level of consumption that this is a source that is making a difference in people's vitamin D status. I just wanted to point out that in cow's milk and then in the plant-based beverages that sort of mimic cow's milk in terms of vitamin D, many are fortified with 100 to 200 international units. The 200 international units is permitted in the US. And there is at least one company that is making milk with double the vitamin D of other milks, but it's not required, it's permitted. However, in contrast, in Canada, when we looked at doubling vitamin D, our Health Canada said, well, it's mandatory. It's the same mandatory, it's the same reason why we've always had mandatory vitamin D, and now we're just going to double it. So it's come in, it's not come in with a splash, it's just come in with a, well, there it is, and you can see it on the label now. It's appearing, but I think they're afraid of a backlash, that maybe there are groups of people who don't want their food to be adulterated and maybe don't even realize that it already has many nutrients that have been very effective in combating public health problems. And it's appearing with the new label that we now have that's similar to the new label you have. So I think it's very important, if you want to talk about food sources of these critical nutrients, calcium, vitamin D, and protein, that you should be using the label. The label is there. It's very important. Vitamin D is required on your label, as is calcium. It's no longer necessary to figure out what the DV is. It's usually the highest RDA, but people don't necessarily know that. The actual amount is shown. Here it's in micrograms. And the actual amount of calcium, people are like the DV, the percentage, then they can choose foods over the day that might equal 100%, but at least shows the value. Now, in terms of protein, what I think the protein amount on the nutrition facts label is good for is to help screen food choices. For example, different plant-based beverages have different amounts of protein. And then compared to cow's milk at 9 grams, almond milk has 1. So somebody who says, I want something that's similar to cow's milk, they would have to look through all the choices and pick one that, well, first of all, they have to want to use it, but that maybe has the protein that they would be missing. And the main one there is soy. Now, in terms of vitamin D supplements, said that Canada has this, everybody should be taking one. The BHOF do recommend daily supplements of 800 to 1,000 IUs. The 800 is the RDA for older adults over 70. 1,000 is there because you really can't buy 800. You can buy 400 and then you'd have to take 2. It's not very practical. So 1,000 is just a nice round number that meets the RDA. It's not too high and certainly would be recommended for almost everyone. You would know if it's effective or needed if you did a serum 25-hydroxy D value on that person. In Canada, we don't like people to come in and ask to have that done because that might be all 35 million of us at one time saying, oh, I kind of want to know what my vitamin D is. So they they do restrict getting this not done, and you can do it privately if you like. But sufficiency is defined by the RDA at 20 nanograms per mil, but the BHOF actually say that people should be maintaining their serum 25-hydroxy between 30 and 50. Well, where did the sort of cutoff come from? Is there any real danger in having this extra vitamin D? Well, it's come out fairly recently that as with most nutrients, there can be a U-shape or a J-shape effect. And Bess Dawson-Hughes, who's a very well-known Boston researcher, is showing here from a study she did published in 2022 that this is for falls risk. So we've known that vitamin D can help with balance, and you can see that falls risk goes down as 25-hydroxy levels go to 20, which is where they should be for the RDA. But after a certain point, too much vitamin D is causing increased falls risks. So the range recommended by the BHOF group is let's have a sort of moderate intake of vitamin D to maximize, in this case, risk of reduce risk of falling, and any more might not actually be helpful, at least to bone. Just to end, and I think I only have a minute or two, it really can end with this one slide that I took from the BHOF website. It's really other nutrients of interest to bone. So fiber, vitamin K, magnesium, potassium, boron, copper, and polyphenols. There's evidence for all of these, maybe not so much for boron, but here it is. It has an effect on pathways that are related to maintaining bone health. Copper is the element that's known to be important for skin integrity and collagen, so that makes sense. One actually could put vitamin C in here as well. Vitamin K and magnesium are certainly in the news in terms of people needing it, should have it in their diets. Really, with having a healthy diet that maximizes vegetables, especially green leafy vegetables, a person can really get vitamin K and magnesium in sufficient amounts. Potassium as well from plant-based foods. So our recent move towards encouraging more plant foods in the diet will allow vitamin K, magnesium, potassium, even boron, which is found in vegetables. The intake of these will improve. Polyphenols primarily are from plant-based foods, green teas as well. And there's certainly evidence of things like dried plums as being helpful to bones. So polyphenols have a role to play. And then fiber. So the evidence for dietary patterns such as the Mediterranean diet is that, and this is pretty good evidence because you've got a cohort of 90,000, that the women who, in the Women's Health Initiative, who had diets that really had very few components of the Mediterranean diet, they called it adherence, but really the women didn't know they were adhering. They were just eating what they ate. But their dietary pattern did not at all seem Mediterranean, just a few aspects. And here's all the things that were evaluated, and includes, of course, fruits, vegetables, and plant-based sources of protein. But the women who had diets that were approaching the Mediterranean diet, their risk of hip fracture, so it's not just a BMD study, it's actual hip fracture, was reduced by maintaining a healthy diet that had the characteristics of the Mediterranean. So these are the kinds of studies that are being done, and they're showing that it's the overall pattern that can have a huge impact as well. So I wanted to end with this graph of a flow chart of what will happen when you eat a food, in this case, that contains many different positive characteristics for bone. So in the case of a fermented milk product, it contains calcium. It could contain prebiotics if it had fruit in it. It has probiotics. And on the next slide, it also acknowledges that it's a good source of protein. So all of these positive constituents of this food promote, in this case, they're thinking that even the gut microbiota might be playing a role to affect a lot of different pathways that end up with less bone resorption. And on the next slide, second half of this rather messy diagram is more bone formation. So I think what's going to happen is it's not about a single nutrient or a single food, but products that contain multiple ingredients that are healthy for bone. And there may even be a synergy, other aspects that are working together to make them much more bone healthy than we thought. So let me just finish by saying that the guidelines are showing that over the decades, as osteoporosis research has progressed, the screening, assessment, and management has improved, and there's many options. And we understand that if something is very potent, like denosumab, then we really need to be careful in managing how it's used. And to recognize, though, that some people may have fears about the treatment, and that is something that maybe will trigger more concern about preventing bone loss to begin with. The exercise recommendations are very much more prescriptive on strength, balance, and resistance. And again, we need motivation for people to get out and do these kinds of exercises to protect their bones. Calcium and protein could come from bone healthy diets, and things like calcium calculators can help people understand if they're low in calcium, and then figure out how they might improve it, whether they switch to different foods or they may take a small amount of supplements. And then vitamin D supplementation in moderate amounts, with not assuming that sun exposure can necessarily meet people's needs. So I think we better end there and get back to our moderators.
Thank
I learned
you
a
so
lot.
much. I know I did too.
I learned a lot. Excellent presentation.
I learned a lot too. Just telling you that. To keep up in this field, yeah, there's a lot going on.
So I think you touched on it, but if you wouldn't mind readdressing. So one of the questions that got put in the Q&A, I was diagnosed with osteoporosis. Osteopenia. What would be the recommended start to help stop or slow the progression and development of osteoporosis? My physician was very vague amounts in recommending vitamin D and calcium. So I know you touched on it, but if you could reiterate.
Right. So osteopenia means that the bone loss has taken place, but not at the level that one would recommend pharmacotherapy at this stage. The exercise and diet recommendations would certainly be important. And I think that what these guidelines are saying is, and in the Canadian one said, you know, it would be helpful to have a dietitian with the food, with the recommendations, because physicians have other things that they could be doing. And the exercise, I mean, in going to a physical exercise physiologist and at our local gym, I mean, I've learned a vocabulary that I didn't know, deadlift and squats and lunges, things like that. I mean, these are things that they know can help you do. They can either set up a program, or you can get maybe a video or something online to follow. She's much harder on me than I am on me. So there's certainly, if it's possible in group classes or something, to have that expertise. And I'll just reiterate that it's not necessarily coming from the medical community. It's coming from the space agency. If you want to protect your bone when gravity is missing, these work. And it used to be that when astronauts came back to Earth after 6 months, they were carried away. Now they come walking off because they have been protecting their bones so much better. And the exercise aspect of it really has been quite remarkable. I mean, I hate to say that in terms that what nutrition hasn't quite worked. We all have our own likes and preferences for foods, and I think it's a little more difficult to really put together a perfectly bone healthy diet that everybody likes. So the nice thing about many of the things like Mediterranean diet, there's the blue zone, there's the DASH diet has always been essentially bone healthy. That there has to be that aspect of culture. And just to come back to astronauts, I remember listening to one of our women, and she said, I wanted the cake. I want the cake when I'm up in space. So yeah, we have to acknowledge that. But it's the supplement side is certainly worth looking into if you can't eat things from food.
Okay, perfect. So I think that actually addressed one of the other questions that came up. So I'm going to give you the other two that I have in my box, and then I'm going to push you over to Wendy. What advice for someone approaching menopause who is restricting dairy for other health reasons? That was the first part of it. And the second is they remembered reading an article some time ago about drugs like Fosamax, which built bone, but the resulting bone was brittle. Thoughts on that, or what in the long-term outcomes of fracture reduction by these drugs?
Well, restricting dairy isn't, I mean, the thing about dairy is that, at least in North America for a long time, I mean, both Canada and the United States are countries of ice cream. I mean, we love dairy in all its forms. So there was a tendency to kind of imply that it was the only way to get calcium. And it was sort of a shortcut as well. But there's both naturally occurring, you know, things like kale and broccoli and black beans, and eating healthy, that over the course of a day at different meals, you're getting calcium, or to choose foods that are calcium fortified. And so keep the foods you like, but have them fortified. Now in Canada, we used to have this yogurt that was double in calcium, and I loved it. And then, you know, the company actually went and ruined it by tripling the calcium. And what that did was it made it taste terrible. There's the reason that foods aren't loaded with calcium is that it does affect its taste after a while, or a certain amount. So calcium fortified foods then you don't see 500 milligrams or something because it's just not going to taste very good. Now, the calcium calculators that I've seen sometimes don't have enough foods in them that really allow you to document what you're ingesting. So you might have to, do a little more investigation yourself. For example, the Canadian calcium calculator doesn't have that many food choices. So you would go to the USDA composition of foods and kind of do it manually, but at least you'd be certain that you were getting enough calcium that way. Now, there were some other questions, and my attention span is a little low here.
It was addressing
Oh, the
Fosamax type, yes, and brittle bones being rebuilt.
Well, that's the drug holiday. Yeah, it was recognized. That's true. Yeah, it was the more is better, and we all suffer from that, no matter what we're talking about. And the bisphosphonates were getting into bone and stopping resorption, and then causing the atypical femur fracture and the osteonecrosis of the jaw. So the Canadian guidelines, I know it's in words, but the BHOF guidelines are a little word heavy, but there's an algorithm that says if you take a bisphosphonate for something like 3 to 6 years and everything seems to be going well, then you stop taking it. And because it's there, it stays in your bone for a while. So there's all these scenarios of what happens when.
Thank you,
Okay.
Dr. Whiting. I think we've got a few more questions that we'll take, and then we know we are way over time. So thank you guys for hanging in there with us. And Dr. Whiting, thank you so much. One of the questions was, what are your thoughts on the benefits versus the risk of calcium supplements?
Well, more is better was around early on in osteoporosis guidelines. Our Canadian guidelines got up to 1,500 milligrams of calcium, in addition to any calcium in your foods. Like they just thought, well, it's just all supplemental. And when a lot of calcium was given in the Women's Health Initiative, some people got kidney stones. That was the main risk. And what was happening was that they were given 1,000 milligrams in addition to whatever diet and supplement they were already taking. So they could have been well over 2,000, which is the current UL for older adults. So there were then some researchers from New Zealand who were saying that they thought calcium supplements were causing heart disease. And what it seemed was that the pills were causing esophageal distress. These are really big pills. What has happened over the years is that supplement manufacturers are making minis. So a mini is a smaller amount of calcium, 200 or 300 milligrams, or you can use a product like Tums, which actually is a mini, and only take the smaller amount that you need as a difference between the RDA and your current intake. And you take it over the day. But the risk isn't great, but we're certainly stepped away from large doses of calcium and using smaller ones more strategically.
Thank you. And let's see if we have one, maybe it'll be a quick one. A lot of positive feedback for today's presentation, how informative it was. So thank you so much for that, Dr. Whiting. One question was, if you've got, can you build backbone if you have osteoporosis or stimulate the anabolic process in any way without medication?
Well, exercise is a form of stimulation because it's strain on the bones, and that's what triggers making more osteoblasts, which are the bone forming cells. But I think it's all mostly prevention. And there may be some, when astronauts return and they have some degree of bone loss, they probably undergo a lot of exercises, but they're young men and women. So I think a combination of diet and exercise, but they have to be done fairly moderately as you get older. I don't know if I'm not sure how much bone you could build back, but it's just stopping that trajectory of losing would probably make a huge difference. And then what happens, and I think the Bone Health and Osteoporosis Foundation guidelines go into this in more detail. You have fall prevention strategies. So you build in ways in which you're not a victim of your own house. Reaching up to high cupboards or low cupboards when you're really not able to do some of those things. You have rugs that will trip you. Fall prevention is important because if you don't fall, the chances of you breaking a bone are much less, even though you may have fragile and low bone mass. So you can sort of protect yourself and not risk that fall that could be so devastating.
Dr. Whiting, I think myself and everyone on the webinar is incredibly grateful for your time and expertise today. And I didn't even introduce our team, Dr. Wendy Dahl at the University of Florida, Marie Eric, who is a County Extension Director, and all agents in every subject area. And I'm Wendy Lynch here in St. Augustine with UF-IFAS Extension. Again, Dr. Whiting, it sounds like we need to have you back again, if you'll have us. But again, thank you so very much for your time and expertise today. We have taken so much. I even got a message. They're like, wow, the Build Your Bones makes so much more sense. So this is fantastic, which is full circle. And we appreciate you very much. Thank you.
Okay, that's great. Thanks.
Thank you so much.